किलो ठुलो मासु पलाएको छ, पेट नचिरिकन हामीले शरीरमा ससाना पल मात्र पारेर पेटमा जम्मा 3वटा पल पारेर हामीले यो शल्यक्रिया गर्न जाँदैछौँ। सो उहाँको पाठेघरमा 2.5 किलो ठुलो ट्युमर पलाएको छ, 20 सेन्टिमिटर। सो हामीले ल्याप्रोस्कोपिक विधिबाट पेटमा जम्मा 3वटा पल पारेर हामीले यो शल्यक्रिया गर्दैछौँ। सो सबैजना लाइभ ओके। सो यहाँ हामीले हेर्न सक्छौँ। सो दिस वान इज अ राउन्ड लिगामेन्ट। उहाँको मेन समस्या भनेको पाठेघरमा ठुलो मासु पलाएको र महिनावारी हुँदाखेरि धेरै मात्रामा ब्लड जाने र शरीरमा रगतको मात्रा पनि कम भइसकेको थियो। हर हिमोग्लोबिन वाज ओन्ली 7। कफलाई अलिकति पुश गर्नु। So she had been previously operated. She had 2 babies. One she delivered vaginally and another cesarean section. So there is minimal of.
लाइफ को टाइम भइरहेछ तर यो यस्तो आयो के
ओके
कल आइरहेको
यो फोनलाई माध्यम त्यो सेटिङ गर्नु एयरप्लेन मोड
कुनै यस्तो
Okay, so sorry for the interruption. So this one is the ovary. Anda बचाएर हामीले शल्यक्रिया गर्छौं. So she is only 42 years old. So we will be preserving her uterus. Preserving her ovary. So in the case of huge fibroid uterus, while you are operating and operating via only 3 ports, so it's always difficult to operate on the right side. But basically, if you have good hand movements, then even you can operate on the right from the left. While sitting on the left side also, you can easily operate on the towards the right side. So this one is ovarian ligament. So this one is ovary. We are slowly. Okay. So you can see the ovary is also being cleared. So धेरैजनाले सोध्नुहुन्छ कति ठुलो सम्मको फाइब्रोइडलाई हामीले ल्याप्रोस्कोपिकली निकाल्न सक्छौं भनेर. So because of this I'm here. This uterus is almost 26 weeks size. So huge fibroid, 20 centimeter in size, arising from the fundoposterior region of the uterus. Because of the previous LSCS, we can see there is a bit of adhesion. So there is high vascularity as the uterus is enlarged, and to feed the fibroids, these are the feeding vessels. The uterines are also enlarged. Okay. So this is the pump. I'm trying to be as much gentle as possible and trying to be medially and towards the uterus. So usually what happens if there is huge fibroid, the fibroid itself pulls up the cervix. So this one is the, you can feel the tactile feedback. What is it? So I have many friends outside the valley, outside the Kathmandu valley, who always ask me to put my videos live so that they could see, even the juniors, because they can't visit to me every time to see these surgeries live. So basically, these live videos are for them who are interested in performing laparoscopic surgery and they want to learn advanced laparoscopic surgery. And anyone who is interested in learning the laparoscopic surgery, they are invited to my center. They can see, they can watch the videos, they can see me operating live. Okay. So many people ask me कि यति धेरै ठुलो पाठे गर्छ र जम्मा 3 वटा पाल पारेर कसरी निस्किन्छ भनेर. So basically what we do is we do a hysterectomy र त्यसपछि पाठेघर निकाल्नलाई we use a specialized device called morcellation. We do a procedure called morcellation using the morcellator and we cut down into long chips. The fibroid is turned into the long chips and it is taken out from the abdomen. So this is how we operate. Usually easy to operate and it consumes usually less time. But as the uterus enlarges, it occupies the space of in the pelvic cavity. So you can see there is very minimal space, and with the help of left hand, I am pushing the uterus towards the opposite side, and then creating the space through which I am using my right hand to operate. So there are the large feeding vessels. So these vessels are large. So I won't take the risk. I would rather use a plain bipolar corset to coagulate these vessels. So these are the ovarian arteries. So these vessels have been coagulated. So up to now there is no bleeding. So I am doing it very slowly and cautiously to minimize any form of blood loss. As she is already anemic, her hemoglobin was only 7, and we have transfused her 1 pint of blood. Okay. So there is. So let's coagulate. I will be using again. So let's separate the ovary and the round ligament first. So let's make some space. So the ascending branch of uterine artery is also there. Okay, so this is the space where we can go. There is puncture over the uterine. So no need to worry. We'll just clamp this heart bipolar. So this is the ascending branch. So we have coagulated that channel, camera. Show me over this side. It looks fine. So once you press the uterus, there will be obviously bleeding, but you don't need to bother from the bleeding from this side, from the uterine side, uterus side. Once you will like it both the uterine arteries, the bleeding that would be left from inside the uterus will only come outside, and that will be the bypass of bypass. Yes, yes. So you can see the bleeding has been stopped, and now we'll do a suction to make the more clear, and then we'll go for the uterine. Once the uterine is been coagulated, you don't need to worry. Okay, now, zero. So the now again let's settle it. So yeah, no. So let's separate this the blood away. So as we have this is the vessel. So we'll be coagulating just beneath this. Later, not column. Okay, show me the yes. So this is going to be the curve. The bladder is being pushed away so that we make a safe margin for coagulating the uterine. Sometimes in the cases of previous LSCS, what happens that the bladder is being pulled up, and once you coagulate these vessels blindly, there is a chances of bladder injury. So, so don't panic. If you have any source of bleeding, even that is coming from the uterine arteries. So you see, I've been pushing, making a window. So making a window. So now it's safe to cut this fold, and then I will be applying bipolar over the uterine. Show me the right angle. So let me show me the right uterine. So these are the uterine which I need to coagulate at the area. It's been one sponsor over this uterine artery. So let's do the suction and apply the bipolar regularly. So this is the plane. So this is the cup. This is the cup. And this is the place where I need to coagulate. So posteriorly, it's being cleared. It looks fine. And now this is the right place to apply the bipolar. Let's take out the gas. The main thing is that when you are operating a huge hybrid uterus, the most of the abdominal cavity is being occupied itself by the fibroid. So when there is a smoke, so it doesn't get adequate space to disperse. So little bit of a smoke will also cause fogging. So now you see it's been totally coagulated. So many of the young surgeons they get panicked when the uterine artery starts bleeding. And most of they convert the lap surgery into open one. So now again using serum, serum causes a bit of more gas, CO2 gas emission, the smoke emission. So this one is the cup where we will be cutting the vault. So as she was previously operated, she had previous one LSCS, but still it looks completely, absolutely fine. So I must say you must be happy till now. Sit on the apple. So I think we need to clean the lens. Are you ready, Gordon? Okay, let's clean the lens. So I think it's been 20 minutes that we have started this surgery. 20 to 25 minutes, and we are almost completed on this uh, left side. So let's dissect a bit of posterior. Let's go to this side. So these are the uterus. As the uterus is too large that we can't go directly into the posterior part because the hanging uterus will itself obliterate the vision. So it looks fine. Let's slowly move towards the right side. Okay. The uterine, so this is the plane, the bladder is being pushed, and these are the loose feeding vessels. So I don't want to get any sort of bleeding here. So I will be gently pushing the peritoneum, the fold away so that I could coagulate these vessels more efficiently. Okay, the bowel is just deciding. Okay. So bipolar. So it looks fine. The uterine arteries are here. The thing I want to tell you all is that I'm operating from the left side and there are only three abdominal ports. Sitting abdomen decadenus actually. So you can see there is one primary port and there are two secondary ports. So with the help of only three port, we are operating such a huge uh, hybrid. So so three port. Many people say that three port surgery. This one is not possible to operate such a huge hybrids. So that is why I came up live with this video to show you that you can efficiently using only three ports, even in the cases of a large hybrid uterus up to 20 centimeters in size. The only thing that you need to assume is have that your hands should be very much mobile, and you have good team of assistant, the nursing team, the person sitting in the manipulator, the cameraman, and you can operate anywhere you want, even so from the ports from the left side. So laparoscopic surgery is basically a teamwork. You can't operate it by yourself alone. So if you have a team, good team of nurses, and the same team of nurses, I don't prefer changing my team. So usually I've been operating in this hospital from last 3 years, and I have the usually most of the team members are same. So they understand me uh, what I actually need by seeing my hand movements only. So you see, uterine arteries are is being coagulated on the right side as well, and I think so. We'll cut and again coagulate. How can this one? So I think you should a bit relax these arteries. So the medial bleeding, you don't need to worry too much, but there should be no bleeding from the lateral aspect. So the bowel is just, so we lift it up. So I will be operating in a conference this Saturday, and I would like to invite everyone, every young gynecologist, and even those who are keen on doing laparoscopic surgery. So the people from India will be operating whole day, and in the evening I will be operating a case in this hospital only. Okay. So this is looks fine. So the vessels on the, so these are the uterine bundle. So this is the anterior aspect and this one is the posterior aspect. So I think it's time for the, okay. So this is the space, the uterosacral one, and it's time for the monopolar. The bipolar venous. So we'll again coagulate this uterine, then we'll fill in the lens, then we'll go for the monopolar. Even you have advanced instrument, the bipolar is the most heavy instrument, I believe. For bipolar, also then you can do all any surgery. So let's clean the lens. Pani use. So we are almost at the verge of this doing a hysterectomy. So we'll be cutting the bud, and after then the hysterectomy process will be completed, and then we'll be closing the bud, and the whole huge fibroid will be we'll take it out by using a morcellator. So we are using a morcellator, and I think the morcellation time itself will take around 20 minutes. So let's go for the monopolar. Okay, I think there is a, so you need to coagulate it once again. You see the pulsating? The pulsating uterine artery. A monopolar venous. So many people, even in Kathmandu, get surprised when I tell them that even you have 2 kilos, 3 kilos of fibroid, and that then you can be operated by laparoscopic surgery. So they get surprised. How is it possible? So that is why I'm live today to create awareness not only among the uh, people but also among the surgeons, the young gynecologists, so they can also start doing laparoscopic surgery as soon as possible. Okay, so we are. You see, it's very easy. I think, it's been 30 minutes that we had started operating, and we have almost completed even at the in the case of huge fibroid. So look, it's so easy using monopolar. So using monopolar and cutting such a huge fibroid. Okay, I will show you at the end also the how huge the fibroid is. Okay, here is the smooth. Okay. So we have completed the hysterectomy, and let's look at the size of the fibroid. Okay. So this whole is the whole abdominal cavity. This whole one is the fibroid. So it is so huge and so large. Okay, hysterectomy निकाल So we will be using. So this one is the uterus. Now, light bulb is the. So now I would like to show how the morcelator is being used. Uh, so this one is the morcelator. So this one is the morcelator. This is handy. This is lightweight. So your hand, even in the last case, your hand doesn't get hot even after operating for quite long period of time. So we have inserted the morcelator. And then we'll be taking. So morcelator is being getting ready. So till then we'll be doing a suction. So almost it's been 30 minutes I guess, 30 to 45 minutes. So there are few muscles. I think we need to coagulate it before operating. And the bipolar disease. Light one. So you see, this one bigger. So it's better to coagulate first, then starting further morcellation. It looks fine now. Okay. So let's ignore the instrument that too. So this is too large. I don't know whether you are able to see it or not, but it's too huge. So my assistant will be pushing it towards the pelvis so that I would get a space. Uh, so even you can see, I will get a space. अनि यहाँ पुस गर्नु देखाउने त मेरो मेरो ठाउँमा देखाउनु यहाँ अड्केको छ पहिलालाई यसलाई देखाउनु ओके take it to the pelvis so that so it's been around more than 2.5 kg I guess. Give it to me.
Tooth.
Traumatic. Give me traumatic. So we will be using a traumatic so it will get some grip. So huge fibroid, almost very huge fibroid. Hold like this. Give me the पानी रेडी गर्नुस् पानीमा ढल्नु Fine. So we'll be now using the modulator. The modulation in this, there is always been controversy for using an bag modulator or doing a modulator inside the abdominal cavity. As per the experience, my experience, I prefer in the cases where there we suspect using sarcoma, then only we use in-bag modulation. But when the MRI or everything, or even there is the reports are fine, then I usually do without using the modulator bag. Okay, so push it towards the pelvis. Okay, okay. So here you can see. So this one is the. This is how we take out the. We make the chips, the lung, and we cut it. So this is how. So this one is the cervix. So we'll label it. So this is how this is been taken out. So I'll label cervix. Keep it separate. So the pathologist even gets terrified by seeing that sample in the form of modulation, where it becomes difficult for them to separate even the cervix, sometimes the ovary and the tubes. So it's better to label them. You can simply use a suture. The modulation will take around 20 minutes, I guess. So you see, so this is how the long chips is being made, and the uterus is slowly taken out from the abdominal cavity. So let's take this escalator now. Where's the new oscillator? So we have been these chips can be easily evacuated using the valve and can be taken out through the vagina. Punch सफा गर्नुस् त. So the mostly lesson you need to use both of your hands. So with the help of the right hand, you can grab the tissue, and with the help of the left hand, you can angulate where you want to take the modulator into. So buying a right modulator is very important. Otherwise, in the long term, your hand starts hurting. So we'll be using a new modulator. As the fibroid is too large, so it will be easy and it will save our time also. To make it more smooth and more comfortable. So you can see the change of the sound once you introduce a new modulator. Things becomes easier. A laparoscopic surgery, because of these instruments, it becomes expensive. In open surgery, you can cut the abdomen and take it out. But in laparoscopy, we have to depend on these instruments for taking all of the thing out. And these instruments are not cheap. So this all is the fibroid. New fibroid. So so we have almost taken out, I think, 750 grams. Sisha should have been there, simple like. Okay. So So these are the tissue that we have removed, and I think only 30% is being removed. So more than 2.5 kg. So with the introduction of this new blade, it becomes easy.
Yes.
So only 3 ports. So we have made only 3 ports, and with the help of the 3 port only, we are doing this surgery. So like you can see the size. So with the help of the morcellator, I am converting the whole round huge 20 centimeter fibroid into a smaller elongated chips. I think there is a for you. I cannot back actually. I'm ready to go. Are you ready, sir? No. Okay. The pan में डुबो. So you really need to have a strong arm, in order to move such a huge uh, hybrid. So almost 50%, 50 to 60%, I guess. Even the small chips, you can take it from the vagina, as the bulb is still open. The patient came from, I think, Budwal. Tonohu. Okay, she came from Tonohu, where she had very huge fibroid, and she was told that open surgery is the only option. So even the fibroid is very large. If there is even a small space to keep the port, we can operate laparoscopically. So this one is the 20 centimeter huge fibroid. We have operated up to 22 centimeter in size, and the fibroid size itself doesn't determine that we can operate it laparoscopically or not. I believe that any size of fibroid that can be operated laparoscopically, if there is a place to have a port inside the abdomen. Sometimes what happens, the patient is very thin, lean and thin, and she is nulliparous or unmarried, so the abdomen itself is very small, and even the 15 centimeter fibroid is too large for them, and we can't accommodate the primary or secondary ports where it is very difficult for them to operate it laparoscopically. And sometimes even the 22 centimeter fibroids are seems fine in a tall woman with who has previously delivered multiple babies. So the abdomen is large and the space is enough for us to operate laparoscopically. So I think 25%. This is automatic ready. I think this, the first tray is full.
DNC.
So 20%, I guess. The small thing that the chips will be taken out from the vault also. So I'm mainly concentrating on this bulk. The her vagina is narrow and the cervix has been pulled off. So it's better to take out from the musculature itself rather than struggling through the vagina to take this fibroid out.
Weighing machine.
And now I think this 10 to 15% minimum. So I am going through this whole video because we'll be closing the word. I want to show you that also. And many people, many young surgeons, they have requested me to show me the whole morcellation process in the cases of huge fibroid. After few, take it out from the vagina as well. So I will ask my assistant, sister television is example. So we have kept a ball inside in order to uh, maintain this pneumoperitoneum. I think one more throw, then we will go plus and take this thing out vaginally. You should use your from the it looks fine. It also looks fine. So I think it can come out through the vagina. So please turn off the modulator. The first thing you need to do is to turn off the modulator once you are not using it. So on the button. Okay, so here you can see. So I'll be handling this system non-traumatic material. So this is the traumatic. I don't want to use traumatic because there is bowel. Uh, so sister will pull it from the inside and will take all these remaining fibroids from the vagina. Slowly and gently. Keep it relaxed. So it is all about the teamwork. You can't do everything by yourself. You can't even push the hold for a second. Unpack them. Okay. So a lot of tissue. This is the why the body is being closed in the at the last. Okay. Let's hold for a second. Let's now move towards the smaller chips. And we'll take it in a whole at a time. So you need to be very patient while taking out the smaller ones. So gently one at a time. So we're starting from this side and we'll go to the we can't even leave a single chip of fiber. So we'll be taking every smaller, larger, everything. So while modulating a huge fibroid, the fibroid get into pot and the inflammatory fluid coming out from the fibroid gets released. The fibroid itself is so large and it's been cut into many pieces. So the fluid inside the fibroids get dispersed inside the abdominal cavity, and which can cause some inflammatory reactions. So I always prefer through washing. So we can see. So okay, so it looks fine. Again, we'll make sure the most sensitive. So there are some chips over here also. So I will make sure that it also gets out from the abdominal cavity. So this is one over here. So I will take it off. Put closer ready orders. Now, someone ready? I like this one. So the urine is clear. Sister, kindly check the color of the urine. तपाईँ निकाल्नु सक्छ clear, right? Okay, so the urine in the urobag and even in the tube looks fine. Urine is clear. Yes, well. So let's close the bud. Then I will get one more hand to open. Okay, there is one fiber over here also. So we'll take it out. So this one is the port closer. How many of you have seen this or not? So it helps you to place the port more easily. So this is the one. And it is all this. So less is over the answer. So we are almost at the end. The patient was anemic. Our hemoglobin was only 7. And you can see there is minimal blood loss. Very minimal blood loss. And we have operated it. Till now it looks completely. Wait for a second. So you lift it up. So there is. So after a, so this is one tissue. So let's close the port first. So this port, the must need to be closed as it is 15 mm port. So my assistant is helping me. So I will do a. I prefer usually taking two sutures, but if you want to take only one, then also it's fine. But taking two sutures makes me more confident because you have manipulated that area. I've been manipulating those areas for quite 20 to 30 minutes while using the mosquito. So it's better. So now it looks completely fine. But I will not be tying it because our surgery is not being completed. So 10 mm port, we'll be using a reducer and we'll be doing a through washing first. Or we can take that out. Let's take the tube out first. Uh, Sarah, only two steps are remaining now. First, we'll be doing taking this self-injectomy. She is only 42 years old. So we'll be preserving our ovaries. So while taking the tube, make sure you are not damaging the ovarian vessels, and that would even cause premature ovarian failure, or even the menopause would, even though the ovarian function will get reduced. So make sure you are away from the ovarian arteries. So both of ovaries looks completely fine. So I am using. It's always better to take the juice out. Sometimes what happens that the fluid gets filled in the tubes, and then people will say that you again the cyst arises. So and there can be chances of infection. So if there is no use of tube, then it's better to take it out. Okay, so sister, please take this out. And there is one small fiber also in it. So we'll be doing a washing. So the only process that is bulb closure is only left. Other than that, we have almost completed the surgery. We'll be doing a washing and checking if there is fibers. So this one fiber. So we'll be checking for any remnants of the fiber. So see, let's check fiber literally for this whatever. So we'll be checking if there is anything that is left. So we'll be checking each and everything that we see. Like head of one. Take this one out. So everything is permaculate. So through the body itself, the fluid will get drained. So I don't need to soften. I just only need to irrigate it. I prefer giving laxes in a normal tendency patient. That will help to see the ureter as the furosemide itself will cause stimulate the ureter, and the peristalsis can be visualized. Get downward. Get down. Now, पानी ready गर्नुहोस् र हामी अब नेक्स्ट get the sugar ready also. पानी लो. पानी ग्यास बन्द गऱ्यो. Get close the one. But okay, the gas is getting filled. You can see. So we have only made 3 ports. So many people certain prefer placing the port from the designer, but I don't want to contaminate the this suture, so I usually prefer from the abdominal route. Sometimes there can be infection inside the vagina, the discharge, and the angle will be secured. So many people have their own method of closing the bud. This is the most traditional method. So I use simple bitery. Many people use nowadays barb suture even to close the bud. But I believe that this suture works equally better and it's cheap. Now let's take the last series. The more number of cases you operate, the easier it becomes. So till date, I have operated more than 3,000 laparoscopic surgery in the last 4 years, 4 or 5 years, I guess. Okay, so let's see the ureters and then our surgery is been completed. So we'll do the dye test also. Rajendra, that's one. That camera back. You angle. So from this angle. Okay, so it looks fine. So the ureter, left side, everything is fine. Okay. Now at last we'll do a dye test. So dye test for me.